All, welcome to one more show. This is Dr. Mubeen Syed, and with me now, the world famous and popular young man, young leader, Professor Dr. Terrence Kommal from South Africa is with us as well. Uh, Terrence, welcome.
Thank you so much for having me, Dr. Mubeen. It's absolutely awesome to be with you.
Awesome. So, thank you very much for being here. So, the discussion today, as a fear mongering and as a scare continues, and we still do not know as the things evolve how they would turn out. But in this meantime, in this evolutionary time, there are people who are trying to dispel the myths and rumors, and there are people who are trying to propagate the myths and rumors. And both parties are doing whatever best they can. So, I wanted to make sure that we continue to be able to provide the balanced view to the world. And Professor Dr. Terence Kamal has been uh, instrumental and very, very helpful to figure out the data from South Africa. So, with this, the discussion today is to look at South Africa's latest number. He was actually showing me some numbers that he got 4 minutes ago. So, hot off the press, what is going on in South Africa, how worried we should be, especially with the UK news that UK has really, they look like they're in a lot of panic. So, once again, welcome, and shall we start?
Great. Thanks so much for having me, Dr. Mubeen.
Very good. So, what I'm going to do is, before we look at your data, I want to share some of the things for references on my side. First of all, this is drbean.com. If you're looking for the medical lectures, this is an awesome place. Then, here, this is Dr. Terence Komal's YouTube channel. So, please go and subscribe. I think you will not regret it. You would enjoy it. So, here is the link uh, to. So, I just posted the link um, in the chat. So please, there are 1.3 thousand subscribers. I hope that we double up this number within next 2 3 days. But thank you very much. I think it is worth it. Then here is the Gotenks or Hotengs data. And once again, this number, remember, it had actually touched 11 12,000 at some point. Now it is actually down. And this is the cases. And finally, if you look at the ICUs and admissions and ventilations, they are still down. Admissions may be there, but look at the ICUs and that is down. So that is interesting data. Then here we look into this later. This is South Africa. The current peak has gone bigger than others, and this is the South Africa's. I hope I'm not stealing your thunder. I just want to level set us for where we are. This is the death rate, 7 days moving average, and it is down. Compare that to UK. So this is UK. This UK seems to never have come out of this wave. If you look at this wave on my voltometer, you can see that this wave, what is this? One, two, three, fourth wave. Fourth wave actually has waves on top of the waves. So they are just continuously in this state. Again, the death rate is more important compared to the cases because cases are cases. Look, death rate is low. And here is the UK's death rate here as well. So even now, I do not feel that there is a need to panic. With this, I'm going to go back to Dr. Terence Kumal, and here is your slides. Here
Awesome.
are your slides.
Thank you so much, Mubeen. All of this data is sourced fresh from the National Institute of Communicable Diseases in South Africa. There are some anomalies, which I have mentioned in our previous discussion, which I will touch on again. But to me, and to contextualize this, we're chasing a live moving target. We're trying to get real-time data. And what's important for that is the world wants to know and is relying on South Africa to say, what is happening today? How many of these cases are Omicron? What are the complexities? We're telling the world there's a higher transmissibility. Do we have facts of that? We're saying there's vaccine escape on those really small studies that were done, although done scientifically. But do we have more data to confirm that? We're inferring immune escape, vaccine failures, potential risks of concerns of seriousness, but I'm not seeing that on the data. And that's what's important that I want to tease out from this data with you today, as much as I have right now. Are the admissions going up? Indeed so. Are the cases going up? Yes. But we'll touch more into the numbers as we go through this very briefly. In terms of South African data, I tried to get the latest data as of 30 minutes ago. The new data for 15 December was due. It hasn't been published. So this is numbers from 14 December, 23,884 cases, a detection rate of 34, almost 35%, which is significant. But what one has to be aware of are people have more time. They're on holiday, they're traveling, they're in different places. So they have more in my thinking at this point, and I hope there are other factors that's influencing this. There's a large amount of people who are saying, I want to know. And what's important to keep in mind is these cases are not only cases from formal PCR testing. Over the last 3 or 4 days since our last discussion, I discovered there's been a large dump or addition, formally so, of antigen and antibody testing results that are being reported by various private sites that are being added to these testing numbers. So people are not saying, I think I'm symptomatic. They just like to know because they're going on holiday. As of today, effectively, because tomorrow is a public holiday in South Africa, i.e., a long weekend, it is almost deformalized or the informal corporate break starting right into festivities right now. And that may influence as we look closer over the next few days of the move of the trend, because there's potentially a large number of the population of Gauteng, which is close to about 16 million people, moving to the coast and other places. So that may help change the data and indicate, is it location based or is it people based, and these movement and social issues. In terms of new cases, I'm just keeping this in context of what we did 4 or 5 days ago. 5 days ago, South Africa was having an average of 19, almost 20,000 cases. We now have 23, 24,000 cases. Is that an increase? Of course it is. It's significant. It's concerning. In the context that there's this panic around the world of talking about the severity and the reinfections and the concerns of potential risks of Omicron in South Africa, as well as across the world right now. This is just for those who may have not watched the previous videos, but to contextualize this, South Africa told the world we potentially had a 74% prevalence of Omicron based on the data from the 1st of December on only 312 samplings. On the 8th of December, the number was updated, but what was mysterious to me and concerning, as Mubeen and I deliberated on, is they weren't updating December cases on new samples. They were still updating November cases 1 week into December. And this is concerning because we've told the world, watch this real time and we'll give you data. But we're now doing historical numbers, which to me, I say with immense respect to my peers, it's almost useless at this point. We don't want to know what happened in November. We want to know what's happening right now. The world, you and I need to know that right now. And interestingly, this is data that I found published today, but it's data dating back to the 10th of December. If you look at the actual numbers in South Africa, yet again, there's now reporting of 630 sequencing done across the whole of November. But again, with my critical concern of why are we doing old samples? We don't need to know so much of November. You've doubly told us what we know in November. Awesome. What's going on 2 weeks into December, midway through the panic in the festive season? Interestingly, and I'm hoping there's new data coming out tomorrow, usually on Wednesdays in South Africa, the previous sequencings were coming out week on week. There's only 61 sequencings done or reported, at least at this point, for the entire of December. And that's distressing. We're halfway through the month. For November, initially you showed us 249, then 300. We're now a fraction of that number, which is distressing. And one of the slides presented by the NICD, which is equally worrying, is they use these great pie charts which show a big number of saying Omicron in bracket 21,000, the number sampling 61%. They found 61. And in bracket, it creates the impression of 21K.
So I want to add a quick comment here. This is, you said it is distressing. To me, it is angering. And here is why. Whenever we talk about, let's say, a vaccine side effect, and for the disclosures, for the full transparency, I'm a pro-vaccine person. I have my vaccine. My whole family has their vaccines. But whenever we talk about vaccine side effects, which is part of medical education, the folks start coming in and saying, well, these are small studies, small number of cases, rare cases, blah, and we shouldn't talk about them and we should not discuss them. And here the studies are coming in, which are preprints, not even peer-reviewed. 12 cases here from South Africa study, which are 6 vaccinated and infected and 6 not. And then the UK study that is once again picked up by media to make it a big giant out of it, that has a total of 43 samples in it, 22 for one vaccine and 21 for the other vaccine. And the authors continue to say, we do not have the data. And then they continue to provide their conjectures as well. For example, they said, we have no data for the vaccine efficacy. They proved that the vaccine titers have gone down to 0. And then they said, but we still think that cellular immunity is still there, and because of that, the vaccines are still good for hospitalization and prevention of the severe cases. And that nobody's coming up and saying, why are you taking these small data samples and using them to create this huge scale of fear in the world? The fear and nervousness itself causes problems too. Well, anyways, that was just my quick rant. Back to you, Trent.
No, I agree with you 100%, Mubin. And maybe just to take your point further, I had a conversation with a esteemed colleague of mine in academia, also a clinician, 2 days ago. And she was pushing and fighting because she actually had side effects as a result of the J&J vaccine. Significantly so, but I won't get into the confidential detail. But it was something that needed to be reported. When they actually did her sampling to check how much antibodies and immune response she has based on the J&J, and remember we were told you only need one, you're okay. This is what we were told last year. She has zero response available. The body's not going to respond to anything. It is as if she almost hadn't had a vaccine. Ironically, because she had an adverse effect or an adverse outcome, she was then denied getting a booster. And I'm like, wait, hold on. So you're saying it's safe, she has no immunity, she has a significant side effect, and she says, I want another one because I'd rather manage the risk of a side effect. But simply put, I don't want to die from COVID. She's advanced age. And they said, no, you're not eligible. And I'm like, guys, wait, hold on. Somebody help me understand this.
Yeah, and there is this is a problem. Even the study that I showed yesterday, 43 samples, there is so much of the reaction that is continuing to go on. There is so much of the projections that we are in trouble and million cases per day, and we are going to be a lot more in trouble in these coming holidays and Christmas and New Year. But nobody is saying this. We are reacting to 43 sample or 12 sample in vitro studies,
Yes.
and not understanding that there are also people who are saying clinically we are fine. So we not me, but the general public, the media, the mainstream, the politicians, the administrations, they are saying we are going to ignore the equal sound of the the clinical side is not that bad, but we would keep looking at these 12 samples and keep saying we are in trouble. This is not correct. At this time, the right way to look at this is, number one, look at the cases. Number two, look at the severity in terms of going to hospital, getting oxygen, and going into an ICU and unfortunately dying. That is a whole funnel that needs to be looked at instead of just the cases and then shutting down everything. So, anyways, more rant. My apologies. Back to you.
No, I appreciate it, Mubin. And I think, we will get more into some of the detail at this point and what they're doing is, sorry, there's some new data coming in. Okay, so I'll get to that just now. But let's look at the slide, which to me is distressing. And, I didn't want to use the word angered, but I agree with you. If you look at the slide right on the top, it says sample number 61. You make a big red dot saying 100% are Omicron. Awesome. You've only done 61 of more than 22,000 available samples on the 14th of December. Although this data is from 10th of December, the numbers were almost equally high at about 20,000 back then. There's no 20,000 Omicron proven cases or sample size. There's none of this. You have 61, and that's the outcome of the data. What frustrates me, and I say this with great respect and humility to some of my peers, this kind of sampling and data reporting wouldn't pass the proposal stage for an undergraduate paper, let alone a national statistic. And I appeal for somebody to show me wrong and show me different. But this kind of representative data will never get past a supervisor, let alone a national government in an ideal world.
And yesterday, I mean, to compare this, yesterday I saw UK's daily report and technical briefing. And in that, they said that we are using S protein signal fault as a possibility for Omicron, but this has been the same test that has been used to identify Delta in the absence of a sequencing. So this is going to be a mixture. So we cannot say this is 100% Omicron or Delta. We think Omicron may be more, but we have a smaller number of sequences. The rest may be both or either. So meaning they clarified it, they gave a footnote to say, be aware. So here, if they're going to say Omicron 21,000, there could have been a footnote somewhere or an asterisk somewhere saying, this is a projected thing. We think it is this, but this could be Delta as well. And then move from there. 61 is a
Absolutely.
very small sample, anyways. Anyway,
Indeed.
back to you.
Awesome. I think we've gone in a lot on this one, but let's move on to some of the true numbers, which I think you mentioned are critically important. Just for those following and may have not necessarily watched our previous discussions on this, on the 1st of December, South Africa had about 2,000 cases admitted. Importantly, for those watching, the ventilated patients were 112 on the right-hand side. That's the important measure for me of how much oxygen and how much ventilated patients there are. We then move on to the 15th of December, i.e. cases as of what we have now. The admission rates are much higher. We're talking 3x, 4x, almost 4x at this point. In the ICU cases, yes, the ICU cases have increased. If we go back, we see ICU was 235. We've got a slightly higher number here, but it's doubled. The ICU cases have doubled, but the number of admissions are 4x, which in my opinion means it's actually getting weaker or there's not as many serious cases. And I'm drawing an inference here.
Understood. So let me just reflect it back to you as well. So you're saying number of people going to hospital or getting admitted in the hospital is 4 times the previous waves. However,
no, this wave as in 2 weeks ago.
Okay. All right. And then from those who are ending up in ICU is 2 times, right? It's not 4 times, it's half of
Correct.
So it's not in sync with the people coming in the hospital.
It's almost halving. If you're correct, you're in the right direction. So if there were almost 2,000 cases admitted or 2,500 cases, we're now at 7.5. So we don't have a direct correlation, but close enough. But the ICU cases aren't on trend. And here's what's important. If we look at the slide again, 112 cases ventilated, and that's my proxy, like one would use the S gene, to the severity of significant and illness and need for intervention. Currently, it's 190. We're less than double the people being ventilated, but the numbers close to 3, if not 4x the number of people being admitted. That doesn't correlate.
Wow. So that is a quarter of the people compared to that's very interesting. So my inference, at least on the data that you're showing, and my inference is that the severity is reduced, and that is why people are less in ICU and they are less on ventilators.
Very much so. That is my presumption based on the actual admission and the clinical data. This is 18 July, just to contextualize it for everyone. 18 July, there were 1,400 people on ventilators, almost a 9 to 10x requirement, and the admissions were significantly higher. I won't go into too much detail. I've got a slide here that's important, which gives you a trend analysis starting from about May, going to mid-July at 14,000 cases. But this is where I'll enhance that information. If you look at week 27, 28, thereabout, South Africa had about 14, almost 15,000 admissions on a 6-monthly review, if you look back. If you look at total admissions right now, we're less than half those cases. The last column of week 50, I'm not going to comment the exact last graph on the right-hand side because the week isn't complete. So I think it's going to be incomplete data at this point. But at least it shows you mid-peak and see how the numbers exploded from 8 to 10 to 13 to 14 in the middle of July during Delta. And in this case, it went from 1,300, 1,300 to 3,800 to 6,800. But it's not in sync. Although there's some data, and when you're doing a 7-day moving average and you're making the data work for you, it creates the impression that it's faster. I'm not seeing the number of cases growing faster correlating with the same speed to the number of admissions, just purely on the data set.
So that's very interesting. Do we know that the number of cases in general with this peak, have they become larger, the total number of cases, than the previous peaks, or that still is a function of time and we got to wait a little more?
I think it is a function of time, Mubeen, because here's one of the 2 caveats. Late November, literally, and I'm not sure, whether it was accidental or for other purposes, but one day after we announced to the world, or South Africa announced to the world, that the Omicron variant was found, suddenly there was an explosion, as you've seen across the media, mega explosion of transmission of cases, 20,000 cases were reported. It was now reported last week by an investigative journalist in South Africa who discovered that the data that was shown to show this massive explosion 2 days after the Omicron discovery, as we call it, was actually a historical data dump for the last 18 months that they conveniently had failed to capture previously. So it looked like the
Hmm.
data was almost bolted in to support the sudden find, and that accelerated panic. A lot of the UK and other media headlines shows South Africa's epicenter, mega explosion. But when a journalist puts out an article saying, listen, explain to us how this happened, no, we apologize for the misrepresentation of the data, that doesn't make headlines. And that is disconcerting to say the least.
Got it. So I want to add a comment here. Beverly Whitney says, and Beverly will trust the numbers you are saying. She's saying, "Good evening, Dr. Bean from the UK. Data for today: 78,610 new cases, up 19.1% last 7 days, and deaths 167, down 5% in last 7 days. Hospitalization 774, up 10.4% in last 7 days." So Whitney, thank you for the Beverly, thank you for the data. So if I arrange it, you're saying 78,000 cases, then 774 hospitalizations, and then 165 deaths, and the number of deaths are actually down, hospitalizations or cases are up, which once again, if I infer from this data, is an indication of less severe outcome. What do you
Absolutely.
think, Trans? Does it?
I agree with you, Mubeen. And maybe, Beverly, thank you for this because I think it couldn't be more perfectly timed. My next slide from South Africa talks exactly to that. In the middle of July, we had a peak week of 3,000, almost 4,000 deaths. It kept in the trend of 3,000 to 3,500 on average deaths across July period, and then it trended down. Death rate in South Africa now over the last week or two has been at 104, 220, 138 reported. And this is data from the NICD as you see the credit on it. Here's my thing. We're looking at what? 20x difference of reduction in death rate, which if we even take the data Beverly says, which I can accept at this point is most likely true, then the trend is if Omicron is at some point the prevalent variant, then it is less lethal and less need for panic as has been created.
So I am hearing there are doctors, professors coming out now and saying this whole idea that this variant is milder, is all BS, and it is incorrect science, and they still think it is more lethal. I cannot imagine how, in the name of science, both sides, all sides, in the name of science, they continue to put their point forward and then they say this is science.
Yes.
Are you still hearing that the cases are mild? I mean, from your clinician friends, from your own practice, do you still hear that the cases are mild and they're better managed?
Yes. I think by and large, and I can speak on a personal experience, my close family friend and a legal professional, very well, good people that I know, probably of the entire 7 family members, 4, if not 5, are positive, very mild flu-like symptoms. Interestingly, I suggested to them on a very well-detailed consultation with them that there may still be some benefit of using the likes of chloroquine and Tamiflu and others. And they said literally the day after starting the treatment regimen, which is a regimen I had got from Qatari sources at the early days of COVID, more than 18 months ago, they said the symptoms were down 90%, which when we spoke of chloroquine reduces transmittability and production, and Tamiflu could help reduce the replication, etc., without getting into the detail, it was a phenomenal result. But the symptoms were significantly milder than what I've seen in patients and family that I lost in the past months that had significant COVID. I've had a system, one of my very close cousins, who was at a point where when we did the normal bloods that the routine GP had done, she looked okay in inverted commas. I sent her for more bloods, and my gut feel said, coming from an anesthetic background, let's do gases. And on the gases, I don't think she would have seen sunrise the next day. She looked significantly ill on the immediate blood gas results and the metabolic state in which she found herself. We got her admitted. Thankfully, she wasn't ventilated. She was treated with high flow, 50 liters, nasal, high pressure oxygen. She's recovered. She's well. She's fine. She does have significant symptoms of long COVID at this point. But that's a very different picture from what we're getting now. We're getting pictures now that look almost like the seasonal flu, which is a positive result. Again, please, I qualify this as anecdotal on personal experiences. Some of the academic hospitals, if I may be just mention on that, as I'd mentioned in the previous discussions, there are some ICU admissions. It has increased. Some of the high cares are up. From what I understand, there are 4 patients at a significant hospital in Gauteng, an academic facility, very large referral, tertiary or quaternary center in which most cases or severe cases are referred to. They've got 4 patients in ICU at this point. One is a medical patient, and they don't know if the other 3, given the data I've got now 30 minutes ago, is whether they're COVID or not. Most likely, even if it's 3, we're talking 3 ICU cases across a large region of Gauteng, which is a referral hospital and an academic hospital, which points to some positive results. The high care has 13 cases, which means at maximum capacity at this point, not requiring ventilations. Sorry, I'm just reading from notes, and I apologize on this inconsistent, but in total, there's 4 patients admitted from the hospital, but not all of those patients in the entire academic referral center hospital for the province are ventilated for COVID. They could be surgical cases, they could be medical cases. They are patients, from what I see, surgical abdomens involved versus true COVID pneumonias. So these are sick patients, but we don't know if 100% of them are COVID related or not. But again, based on the data I shared in a previous discussion with the great, my appreciation to Mubeen, is that hospital had more than 80 to 90 patients in ICU kind of environments now 4 months ago in the previous wave. But if you look at the death rate, it correlates to the picture.
That's a very interesting one. So, for the cool beans, the chart here is about the death rate, and this is in private and public hospitals, and the data is from NICD, and the hospitalization, the death rate is really low, which is a good news, and I pray that it stays low as well. Um, uh, Terence, I have this comment from Chris Bell. He says, and let me bring you to the full screen so we can see you. Chris Bell, Witty here, UK, now saying that the indication from South Africa regarding milder cases are misleading due to difference in immunity between Delta wave and Omicron, and because it will be overwhelmed by more cases. I guess what essentially he's saying is that a lot of population is already protected, so of course they're going to get milder cases. However, what I had heard was that even in the unvaccinated, or as we say, uh, immunologically naive for SARS-CoV-2, or those whose immune system does not know SARS-CoV-2 either because of a vaccine or infection, I thought that they were also doing better. Have you heard any of that from the unvaccinated data?
Based on I have on what you're saying, Mubeen, I've heard that a larger volume of the cases being admitted are patients across the board are patients who are unvaccinated. But it does not translate to they are, and that data we don't have. Ironically, nobody's sharing that. Is how many of the unvaccinated patients are directly going to ICUs and being ventilated, and how many of the vaccinated patients are being able to do that? Because that to me would be a true indication. As we spoke previously, the samples of 6 and 6 patients are awesome when you're using blood samples that are 18 months old or 15 months old. But when you have real live cases right now, you have the data available to know who's been vaccinated, who's not, what are their age groups. That's what you, I, and I think the world deserves to know at this point. How many of the patients are vaccinated or not? So it shows us whether, or at least we can use that to infer that the vaccines are working or not in terms of seriousness, and what is the prevalence of admissions of those being vaccinated or unvaccinated. And I think we don't have enough of that. What our learned colleague on the question you shared said, I think there may be merit in that, but I think it talks directly to comments that you and I have been saying is the fact that you had prior exposure may most likely be good for you. But the point I'm driving home, or the point I'm trying to make is it's not as serious as they've made it in the past, because not only is the world, and there's a collective discussion from not just South Africa, but many other sources, Omicron could be more deadly. You're getting a large amounts of immune escape. That means the vaccines are not working, as well as there's a large number of reinfections. We're saying that on multiple headlines. That does not correlate with what our learned colleague from the UK is saying. Because if you have been exposed, and the milder cases are because you have been exposed, and as you've said, Mubeen, we're not talking naive cases, then I agree. But that's not the narrative that's being shared. The science and the data is disjointed to it.
And there is one more important thing to consider, and that is we're talking Omicron only for a couple of weeks or 3 weeks. Before that, it was Delta, and there was all of that hoopla going on with the Delta as well. And the society structure was almost the same. It is not that in 3 weeks the whole composition of immunity and protection has changed drastically. It was the same society. So the number of deaths, if it is lesser than what Delta was, Delta at this time was also looking at the same composition of society where some are protected or have training and some do not. And this was the data. And compared to that data, this data looks better for severe cases. So we have to agree at some point to say, well, both variants had the same composition available to them. One did seem to be more deadly and the other one did not. And that should be an acceptable data point.
Absolutely. Mubeen, if we could potentially just share that, I'm struggling to pull up that slide.
Let me do this. So let me add, hold on. It says remove. It says it's already being shared. So hold on. Here.
Oh, there we go.
Is it?
Thank you so
Yeah.
much. Thank you
Yeah.
kindly. But I think this may talk to the data I forget his name, but our colleague had asked, is importantly, if you look at the blue bar charts to bring everyone into context, the blue bar charts are samples or sequencings which we can use to infer in South Africa during the beta variant. So there were significant waves during the second wave. Then the green bar charts are the Delta wave, and now the red being Omicron. Please do not interpret it as it's presented, because 61 cases, 100% of 61 is very different from 80% of 4,200. It's very, and I say with great respect to my peers, it's mischievously presented, to say the least, if not badly presented.
Absolutely. And I'll give you another example of how this data was presented. Uh, a similar data. So I'm going to share my screen for a second. Here, let's say we go to South Africa. This is the number of cases. A few days ago, the number of cases were in this area. However, if you had gone to the percentages, so for example, I think this is a chart with the percentages. This is the percentage of increase. So if you looked at the percentage of increase, you would say, man, this is the largest ever uh, peak we have. And the presenters I was seeing were not clarifying that this is the growth rate instead of the actual absolute numbers. And they were presenting this and just causing a lot of scare. So the data that I just saw from you, where is that? This one. This one is the same thing, that this is percentages. So the green bar is, for example, a percentage out of a larger number, and then 61 is really 100% of 61. So that looks larger. Very, very
Yeah.
interesting. Thank you very much.
And I
Okay,
think
so
that's the thing, Mubeen, as your colleague had mentioned briefly, just to round it off, is if we're saying there is milder symptoms in patients who are pre-exposed to Delta, hence it's milder in Omicron, why didn't we see that for those who had Beta and then Delta came around? Actually, Delta was disastrous. So I think Delta was most likely more lethal and significant based on the 3 to 4 weeks data we have now on Omicron, because it's not keeping in sync with the same trend.
correct. And I find it strange that, so there can be two groups of people. One group may be who are saying, hey, uh, I just do not want to be happy yet because who knows, there may be a problem. And so I want to wait. And totally fair. And then there are folks who I feel do not like this situation. And they continue to find reasons to say, no, 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 this is actually bad. You are just not seeing it correctly. And I don't think that that is a fair thing to do at this time. We need to get out of this mindset of continuously scaring people. So, Trent, tell me generally what is the mood in South Africa within your clinician colleagues, hospital friends? How are things in general?
There is no panic given my circle of friends and colleagues. it's people are actually considering, is it possible we may actually take a festive break or holiday, because it's summertime out here right now, and people are saying maybe we can afford a few days, because remember, nobody had time for most of last year. December during the second wave was a disaster. So was the July period in winter. So at this point, colleagues are saying maybe we can take some time away, because I can tell you now, 6 months ago, it was all hands on deck and every single resource was stretched. People had no idea which direction they were going. Not just physically, but mental exhaustion was at its peak, or at its worst. At this point, we are in anticipation, worried, we're concerned, no doubt, because we have no idea which way this can go and change in any direction. It's completely unpredictable. But given the trend that we have, I don't think there's as much panic as we had 3 weeks ago when we were told all hands on deck, this is going to be worse than Delta. It hasn't got there yet. I'm not saying it won't, but importantly, there's also been comments on children and children's admissions and death rates. There is just one slide I want to just share, which could be useful. Thank you, Mubeen. And this is cumulative, please. This is not now out of Omicron or anything, but as a trend in South Africa, it most likely looks at people from mid to advanced age who already, and I'm making a presumption and I want to qualify that, a large amount of the patients beyond the youth, if I could call it, may have a higher risk of chronic diseases and other comorbidities going on, and hence the possibility of mortality. But there has been a lot of panic around the world about it being transmitted to kids. One, because they're unvaccinated. Two, they're transmitting it more aggressively, which is very likely and possible. But in terms of mortalities, when we're telling the world to panic, kids under 5, kids under 10, teenagers, the total death rate reported in South Africa as of today is 26 people under 9 years old from the beginning of the pandemic. That's almost 18 months to 20 months ago. That's very positive information, which is inconsistent with the allegation that Omicron moves faster with kids. Or it may be moving faster, which cannot doubt given the data we have, but it's not lethal. It's not significantly to the point where it's causing death. And our kids are vulnerable and unvaccinated at this point.
That's very interesting. So thank you very much for sharing this as well, because there was lots of uh, news as well that it is going through the kids community and causing a lot of destruction there as well. So good to know that the kids are better protected. My comment to the audience here, to the cool beans here, please don't take this as a ticket to say I'm going to be irresponsible. We still need to be irresponsible. Delta is still prevalent in majority of the countries and societies and communities. So please have your masks. If you need to have a vaccine, have your vaccine. Hygiene, social distancing, all that you believe in doing to protect yourself, you should do that. All that your doctors, your communities, your rules make sure that they are helping to protect you. Please keep adhering to that. Do not take risks. We are almost getting out of this. I say this now, it is a year I'm saying this, so my apologies. But uh, don't let your guard down. This is a reminder. Alexa, stop. Sorry. So, Trends, would you be open to take a few questions as well?
Absolutely. If I just have a moment to
Yes.
echo your sentiment equally, to be responsible, is I agree with 100%. And just today I did an interview with the national media, the South African Broadcasting Company, on what do people do, because in South Africa now in summertime there's a large exodus to the coast and to the beach, because it's time to celebrate and be together with festivities. And my suggestion to them, although I have no right to prescribe to the authorities, is if there are these little family groups sitting under the umbrella or together, then it's almost as if you're in a home environment. You're going to be socializing, but keep that within your circle. But the authorities should potentially create some way to separate the groupings of immediate family from others, so there's no transmission. It does not mean you need to not be responsible. Wear your masks when you're traveling, wear your mask all the time, sanitize, socially distance. Because there was also questions of, well, if people are walking on the beach on the promenade, open air is safe. It's safer than indoors, but it does not mean you're not going to touch a railing or touch someone, or there's some suspended droplet in the air that you may inhale at some point because somebody, a couple of seconds before you sneezed or coughed, or for some reason it remains suspended. Those risks remain real and material. the basic rules, and it sounds like we're driving the point home again and again, but those are only current solutions. Besides vaccinations, socially distance, be responsible because you want to make sure that you have another festive season together. Wear your masks and sanitize.
Agreed. Thank you very much. And there are a couple of comments I want to respond to them, and hopefully you can. So P. King says South Africa have a different demographic than UK, Canada, and Europe. So I agree with that, and of course that would mean dynamics will be different. What do you think, Terence?
I agree with that, and I'm not sure how I interpret that, Mubeen, but maybe a comment to maybe qualify how I see it. South Africa has one of the largest reported disease burdens of HIV and AIDS in the world, potentially 1 in 5 based on the oldest data or the most recent slash oldest data I have access to. 19% means 1 in 5 potentially has HIV. If we use that as a proxy to say there's a large percentage of the population that is immune compromised, it could create an impression that South Africa or people in within our region are more vulnerable to COVID in total. But we're not seeing that in terms of the transmission numbers. We're not seeing that in the seriousness, nor are we seeing that on the ventilations. Yes, a discussion for another day is maybe the ARVs actually have some benefit in these patients who are being treated for HIV and AIDS, TB, malaria, and others, but it's completely a different discussion.
Got it. Thank you very much. Gunnar says, will Omicron outcompete Delta so that it will be the dominant strain in all countries?
Safely to say, I don't know. Given the trend it's going, and on the limited inferential data that we make, an anecdotal comment may be, if it is as mild as it is, please let it spread. It might be a lot better for us than Delta. Please, I'm not saying COVID should spread irresponsibly so. I'm saying Omicron at this limited data level looks better for us than Delta was.
Yeah, so I agree that Omicron compared to Delta seems to be a better thing for us compared to Delta. And again, please don't go get outside and get infection. So Colombian Coffee Bean says, early on, most Omicron diagnosis was at South African hospitals were incidental to reason for admission. Is this still true?
I say this with a caveat based on my experience between my peer circle, as I've said in the past. But yes, I can say that specifically for the kids, the large number of kids in the academic hospitals in the area that I live in North Gauteng and in Pretoria, were actually cases that were admitted for other medical or surgical conditions. But because of mandatory testing, they came back positive incidentally. So in the adult population, I cannot draw such inferences as yet because I don't have enough information to do so.
Got it. Radmila says, could Sinopharm inactivated vaccine, I think that is from China, I believe, be more efficient against Omicron?
Initial answer would be I don't know, and we don't have enough data. Here's the challenge we have in South Africa. The Chinese vaccine, if we call it loosely, has been licensed in South Africa now for about 5 or 6 months. But for political and other reasons, despite after lots of kicking, pushing, and pulling, and let me contextualize this, the Johnson and Johnson vaccine, to the best of my knowledge, and I hope I'm still correct, was licensed as a trial vaccine when it launched in South Africa and rolled out to the healthcare world. Based on it being a trial, and I think it still is a trial, it was then rolled out nationally across the country as a trial vaccine. When Pfizer became available, it has rolled out everywhere, mostly in the private market, but outside of healthcare workers. Interestingly, when the Chinese vaccine finally, after lots of legal technicalities, and finally got approved in South Africa, the licensees and the Chinese government were told, congratulations on getting a license to distribute in South Africa. The sole procuring agent is the government, and we're not buying at this point. I cannot understand the logic. I cannot understand the reasoning, because if we don't have the varied vaccines, then we won't be able to know whether, as our learned Radmila is asking, is it better or not? And I don't know if there's any incentive at this point to do it. Personally, I think it's very necessary. So we can at least compare efficacy and outcomes long term.
Got it. Thank you. I actually have a question of my own as well, and I'm going to share my screen to see if I can find that question for you or the data for that. So give me 1 second. So this is a study from Oxford. I discussed that yesterday. This is reduced neutralization of SARS-CoV-2 Omicron variant by post-immunization serum. In here, they talked about um, South Africa. So see this here, they're saying early reports from South Africa suggest Omicron is highly transmissible in a population where 60 to 80% already show serological evidence of previous infection or vaccination. So the question in this whole statement, usually what happens is when an author or authors are writing a paper and they have such data, they would put some sort of a superscript there and a reference to say, go here, it's the number 12 study down
Yes.
mentioned, and there you can go and see it. And again, I do not know if you are aware of this. Is South Africa 60 to 80% uh, trained for SARS-CoV-2 either by natural infection or the vaccine?
Based on what I know, no. And my observation was exactly yours, and hence I, I chuckled on it, Mubeen. If you're going to
Hmm.
make such a wild, sorry, respectfully, if you're going to make such a broad, sweeping statement, where's the reference? That's the first thing I'd ask. Show me that study. I want to be able to see that and see if it's peer reviewed. Yet again, right at the top, in the header of this document has not been peer reviewed. Why are we latching on to put out science before we send it to a journal? Why are we sending it out before, at least if it's independently reviewed, or some journalist said, I'm willing to look at it? Then you can
So,
say it's not
so
final, but I need reviewed.
my apologies. I want to be fair to them. This is actually printed in a preprint, I think MedRx, and they say that it is not peer reviewed. So going back to that one, even then, even for the peer reviewed, shouldn't there be a reference somewhere that peers can go and check the reference and then come back and say, yeah, thumbs up, or no, you didn't write it correctly?
100%. I agree with you wholeheartedly.
So this was a shocker for me that 60 to 80% of South Africa is serological, has show serological evidence of previous infection or vaccination. That's a huge deal. If
It
you
is.
are in South Africa 60 to 80% um, good, you're almost out of the pandemic.
Sure. If we could go back to that quickly, Mubin, I just want to pass a comment on the next line, which I think is important.
Let's do it.
Is it, they go on to say, and it is clear that Omicron is able to break through natural and vaccine induced immunity and vaccines to some extent, although early reports are not pointing to severe disease. I disagree, because if this paper is dated the 11th of December, they failed to read the study from our colleague who we spoke about last week, which showed that 5 of the 6 previously infected patients had a significant positive immune response against Omicron. And that's
Yeah, so
data that's available.
yep. And I talked about this study yesterday. There are a number of things that I'm not comfortable with in this study. For example, just as you mentioned this, here they are saying neutralizing titers on sera from participants who had received homologous AstraZeneca dropped to below the detectable threshold. And then they said median neutralizing titers. Here it was neutralizing titer, and the other one is median. So whichever number helped them articulate their message, median neutralizing titers on sera from participants who had received homologous BioNTech dropped 29.8-fold from this to this, with one participant dropping below the detection threshold. After saying this, so from this, my inference is vaccines are not working. Small study, vaccine are not working. Then they would then go down here and say, you know what? Please just quickly go get your vaccines and boosters. And again, I am not against vaccines and boosters. What I'm saying is the data here, when you misconnect it, then people would poke hole and they will become even stronger in their resolve that we are being pushed in one direction or the other. There are better ways to articulate that than doing this. But anyways, this study has a bunch of interesting things. So
Absolutely.
ready for the questions?
Before we go there,
Continue.
Mubin, just a quick comment, on what you said on the paper. And you as my learned peer would also appreciate that. When you do basic studies, any science principle, as you speak of research, talks to the principle of they say, I say. So tell the world what we know already, and then tell them what you found. if you're doing a study on immune response and vaccine response, there's only one other study that's prominently known, and that's the one that came out of South Africa that we spoke about previously. Why not talk to that first and then tell us where your studies were different? You don't mention it. You don't show that their study showed, in my interpretation, an 85% good immune response in those who were previously infected and vaccinated. If that's not your baseline, you're starting in a caveat, and it makes for bad science, to say the least.
Absolutely agreed. Totally agreed. So, and this is an Oxford study. So here is a question. Kira Shrem says, South Africa doctors using fluvoxamine or colchicine observation.
I don't have any information at this point.
Got it. Thank you. More questions. Eddie says, could it be that in South Africa they had a lot of beta variant and that's why the cases are mild?
I would suspect the question would potentially point to Delta variant if we look at the timeline, and it's very possible. Anecdotally, looking at the graphs, it is very, very possible that Delta has created some strong immune response at this point. It doesn't suit the consistent global narrative, but looking at the data, that's what it's showing us. We don't know if it is Delta alone or vaccines, or Delta and vaccines as a combination, and I'm hoping it's both, that the vaccinations together with some form of Delta exposure previously, and that would be awesome for everyone.
And that is what is interesting for me, that on one end it seems like there is a immunity with this, but the media's reporting and WHO's discussions, most of those discussions are picking up those studies, may they be small, not yet fully peer reviewed, which kind of show the opposite side of it. I think we need to get out. I would continue to say it with lots of, as you say, humility and concern that 2 years of fear is a lot of fear in us all. And I do not know when these imprints would leave our brain, or would they ever. I think we should start looking at where are the positive news and see how do we keep scaling that news in reality, and that's the way to get out.
Yeah, I agree
Okay.
with you.
Dale Jackson says, inoculating those carrying the virus, could that have contributed to evolution of Omicron?
Safe answer is I don't know. I don't know enough on that.
And Dale, there has been a doctor who says this, and I do not think that there is much merit in this possibility. I am just looking for the questions. So, Cool Beans, if you have questions, just put Q with them or question marks. That makes it easy for me to go through and find them. So, here is a question from Anthony D. Stefano. Is it true if Omicron is weak, can it still increase a pool of infected macrophages and cause long COVID or cytokine storm?
That's quite an interesting question. Is it true? I think theoretically it's very possible, given that it may have an increase. When we talk weak, I want to qualify this. Potentially, it may be weaker in terms of severity, but it may also cause an aggravated immune response. And there is the possibility of long COVID, but I don't think we have enough cases or time to make that inference. But I think, Mubeen, you're more the immune expert to qualify to maybe guide me on it.
So you're right on that we do not have enough data yet to be able to say that what will it do with the long COVID outcomes. So we'll have to see. Being a virus in the same breed as SARS-CoV-2, they all do this long COVID. So this has that potential as well. Okay, so this is another interesting question. What percentage of South Africans take statins? Could this be a factor?
I don't know what percentage take it, but I can tell you, as routine protocol, patients who are diagnosed with dyslipidemia or high bad cholesterols in inverted commas are routinely prescribed statins. It's part of mainstream protocol. Could it be a factor? I don't know, to be honest. What I could comment, as I mentioned earlier, is ARVs may play a significant factor, which which is something that I don't know if there's enough studies at this point to draw that conclusion or inference. But if it's antiviral, there may be some benefit.
Got it. So our last question for the day. Mrs. Carother says, can you please know of our gratitude for both fine knowledge doctors for sharing their learning and experience with dealing with current crisis. Will Omicron have serious effects with unvaccinated?
Firstly, thank you for it. I'm really appreciative of the positive feedback. In my mind at this point, I don't know whether Omicron should be our concern as opposed to the concern of significant illness and complications if you get COVID by poor decisions of social distancing, wearing your masks, and consideration of everyone that you care for and those around you. That is more for concern for me at this point. Yes, academically, we're going into detail of numbers and seriousness, but I don't know your current healthcare status. I don't know your pre-existing family history and genetic predispositions of risks. We don't know your immune status at this point. We don't know your state of mind. That also has a significant contributing factor. What we do know is we can take some active actions to reduce the risk of getting it and or transmitting it. And at this point, that I think is important to each of us and everyone that we consider near and dear.
Excellent. Thank you very much. So, Dr. Terrence Kommal, thank you once again for your time. Thank you for bringing us the news hot off the press. 4 minutes before here, you have the text messages that you're reading. I love it. And thank you for keeping us sane during this time, especially from the South Africa, where the basic news started emerging from. And I actually appreciate and I'm grateful to South Africa for helping us understand it. And I feel that in the rest of the world, we need to reduce our panic a little bit and be more objective for what we are seeing. Any last comments before we wind up?
Absolutely. Again, if we don't speak, and hopefully we do in this festive period going forward, I want to wish everyone well through the festive period. It's a blessed time for family and near and dear ones. Let's review the year that's passed and the time we have going forward. Please be responsible, take care of those you love, and be responsible for your community. Be an active participant. And in that vein of being an active participant, I want to express my immense gratitude to Dr. Mubeen for having me with this, but also more importantly, for being such an important contributor in this topic and domain for the numerous hours every day on day, for weeks on end. And I'm actually been following a lot of his work and learning from that. So thank you for your massive contributions and the cool beans who are actively stimulating some of these discussions and the knowledge being shared. And it is a great honor and pleasure to share and spend time with you. Stay safe and stay well through this festive period.
Thank you very much. And thank you very much for being here. We are actually honored to have you and have a nice long weekend. Thank you very much for giving us this slice of time and preparing for it beforehand and while this is your long weekend as well. So enjoy and thanks to your family as well for letting you puncture the long weekends for these things.
Absolutely. But thank you so much. It's such a great honor.
Very welcome. So Cool Beans, thank you very much. Please like, subscribe, and share. And if you would like to support this work, there are some links in the description. You can see them. And I would see you again. Bye-bye.